A very good afternoon to one and all connected. I would like to welcome you to the 94th CME event organized by the Continuous Medical Education Committee, Faculty of Medicine, Bioscience and Nursing, Masa University. This is our 94th event and it is the last event for this academic calendar. I would like to introduce today's speaker to you all. Today's speaker will be Associate Professor Dr. Nilar Kin, who is at the Faculty of Medicine, Bioscience and Nursing, Masa University. And something about Prof. Nilar, she did her MBBS in the year 1999 from University of Medicine, Yangon, Myanmar, and her MMed Science ENT from University of Medicine, Yangon, Myanmar in the year 2006. She has also done her postgraduate diploma in tertiary teaching from UCSI University, and she holds a certificate course in essential skills in medical education from Dundee University, and she also has a certificate in good clinical practice from Ministry of Health, Malaysia. Prof. Nilar started her career as a medical officer in Yangon General Hospital, Myanmar in the year 2000, and in 2002 she became the team leader of Morbin, Myanmar, the School of Health, and in 2003 she joined as a trainee for Master of Medical Science, Ear, Nose and Throat Hospital, Yangon, Myanmar, and in 2006 she was a consultant otorhinolaryngologist, Ear, Nose and Throat Hospital, Yangon, Myanmar, where she served. I think she moved to another hospital like Laikau General Hospital as a consultant. And until 2010, she had been practicing very actively. And she chose to come to the academic side in the year 2010. And she joined as a senior lecturer in the Faculty of Medicine and Health Sciences, UCSI University. And she was promoted to assistant professor in the year 2013 before she joined us in 2021, June, as associate professor in the Faculty of Medicine, Bioscience and Nursing, Masa University. Prof. Nilar is a specialist in otolaryngology, head and neck surgery, and she's a registered specialist in the Myanmar Medical Council. And I think today she's going to actually give us a talk on early recognition of head and neck malignancies. I think I'll not delay much before I invite Prof. Nilar to deliver her talk. Over to you, Prof.
Good afternoon. Thank you very much for your kind introduction, Dr. Deepa. Thank you very much. So today, I am going to talk about early recognition of head and neck malignancies. So head and neck malignancies arises from the ear, nose, and throat areas. More specifically, it arises from nasal cavity, sinonasal cavity, nasopharynx, oral cavity, oropharynx, larynx, laryngopharynx, and some are from thyroid gland and salivary glands. So what are the risk factors of these head and neck malignancies? Actually, it is a complex multifactorial process, and smoking and alcohol drinking are well-known etiologies for head and neck malignancy. Some viruses are associated with head and neck malignancy. For example, human papillomavirus associated with oropharyngeal carcinoma. Epstein-Barr virus is associated with nasopharyngeal carcinoma. Other than that, bitter nut chewing, precancerous lesions are associated with oropharyngeal carcinoma, and consumption of salted fish, that is nitrosamines, is associated with nasopharyngeal carcinoma. For thyroid cancer, if you have the exposure to radiation, there is a risk, and increased risk if you have a family history of cancer. So how they present, head and neck malignancy, how they present. For example, for laryngeal cancer, in early stage, they present with hoarseness of voice. In late stages, because tumor mass is in the upper airway, it compromises upper airway, and upper airway obstruction leads to noisy breathing. We call it stridor. So in early stage of laryngeal carcinoma, they present only with voice changes. We call it hoarseness of voice. So we never thought this is underlying malignancy. This is because of underlying malignancies. So how they diagnose is, some they diagnose as laryngitis in early stage of carcinoma, and they give antibiotics. And even in the late stage, patients present with stridor, they thought this is bronchial asthma. So they admit the patient and give steroid treatment. So what happened to these patients is delay in referral. So late stage diagnosis, late stage presentation. How about nasopharyngeal carcinoma? Nasopharyngeal carcinoma is very peculiar. It has four cardinal features. Tumours is in the nasopharynx, that's why they have nasal symptoms. Other than that, ear symptoms, otological symptoms, neurological symptoms, and nodal symptoms. Nodal symptoms is because of lymphatic spread, metastatic lymph node, so they present with neck swelling. Neurological symptoms is tumours is in the skull base. Nasopharynx is at the skull base. So at the skull base, we have cranial nerves. So the tumor invades these cranial nerves and they present with cranial nerve palsy. So in next slide, I will explain why they present with ear symptoms, even though tumor is in the nasopharynx. So they have otological symptoms. So here the peculiar feature is they present only with ear symptoms. They present with only cranial nerve palsy. For example, lateral rectus palsy with blur vision or diplopia. So that's why they have some wrong diagnosis. For example, if they have earache, they thought this is infection, inflammation occurs in the external ear, and they diagnose as otitis externa, they give antibiotics. And if they present with hearing loss is the most common ear symptoms in NPC, nasopharyngeal carcinoma. So they never thought of underlying malignancy in hearing loss cases. So why hearing loss is in your nasopharyngeal carcinoma? Because in the tumours is in the nasopharynx, and that nasopharynx connects with your middle ear via your eustachian tube. So when the tumor grows inside your nasopharynx, that tumor invades the eustachian tube and it leads to eustachian tube obstruction or dysfunction. So what happened to the middle ear is negative pressure because of obstruction of this eustachian tube. No more aeration to the middle ear, so negative pressure. So what happened to the middle ear because of negative pressure is body response. It increased fluid secretion inside the middle ear. So that fluid collects inside your middle ear, and that condition, we call it otitis media with effusion. So because of this condition, patients have hearing loss. This hearing loss is conductive type of hearing loss. They have conductive hearing. Actually, this otitis media with effusion is common in children and usually bilateral. But in nasopharyngeal carcinoma, it is usually unilateral. That's why we have to be very careful if patients present with unilateral conductive deafness. We have to exclude possible nasopharyngeal carcinoma. So I found one study. This study is in one of the hospitals in Indonesia in 2018 and 2019, and it is a descriptive cross-sectional study, and they have some cases of nasopharyngeal carcinoma, and more than 50% of the patient has conductive hearing loss. So it means hearing loss is the common presentation of nasopharyngeal carcinoma. So to get the early recognition or early diagnosis, we have to understand the red flag signs and symptoms of these common head and neck malignancies. For example, persistent voice changes more than 2 weeks, persistent or unilateral hearing loss, unilateral epistaxis, non-healing mouth ulcer for more than 2 weeks, treatment unresponsive for neck swellings, or referred altalgia, so we have to be very careful. They may be underlying head and neck malignancies. So referred altalgia, why? Because these nerves supply ear as well as other ENT or upper aerodigestive tracts. So once you have the problem or infection or malignancy in upper aerodigestive tract, your brain cannot recognize the exact site of lesion, but they recognize pain in the ear. That pain, we call it referred altalgia or refer pain. So head and neck malignancy cases have these sort of refer pain. So how do you know patient has refer pain and not because of ear problem? Then when we perform ear examination, ear examination shows normal. Then we can understand, oh, this is probably referred altalgia. So for these head and neck malignancy, we have staging. We use TNM staging like other tumors. So 4 stages, and stage 1 and 2 are early stages, and stage 3 and 4 are late stages. So early stages, definitely we have smaller tumor with minimal lymph node involvement, but in late stages, it is locally advanced disease with invasion to the surrounding structures with increased lymph node and involvement plus distant metastasis. If we have distant metastasis M1, then probably late stage, stage 4C. So prognosis, as you all know, in early stages, good prognosis, late stage, poor prognosis. So in terms of 5-year survival, so in early stages, we can expect 5-year survival, but in late stages, we cannot expect 5-year survival. Prognosis is reduced. So how we treat these head and neck malignancies? So usually we have 3 modalities: surgery, radiotherapy, and chemotherapy. For early stages, we can use surgery or radiotherapy as a single modality, but for chemotherapy as a adjuvant therapy. So it is chemotherapy we usually do not use as a single modality, but it combined with surgery or radiation therapy. In early stages, we can expect cure. So in the management of head and neck malignancy, so we have 2 intentions. One is curative management and the other one is palliative management. If we expect 5-year survival, then we can give curative treatment. Otherwise, for example, distant metastasis with increased morbidity, then we cannot expect cure. We have to give only palliative treatment. So even in the curative treatment, in early stages, prognosis is very good. We can expect up to 90% of 5-year survival, but in the late stage, it is reduced. 40% depends on the center and tumor site and nature of the tumor. So here are some examples of the management. This is a tumor mass in the larynx. Vocal cord is it a C larynx? Early case. So in early case, we can do radiotherapy. But late case, like stage 3, stage 4, still we expect cure, then we have to do surgery. That surgery, we call it total laryngectomy. We take out larynx, voice box, and we put that cut end of the trachea attached to the skin surface of the neck. We call it stoma. So after laryngectomy, there is no voice box, there is no larynx, and patient cannot speak, cannot communicate. That's why we want to preserve the organ. We want to preserve the larynx, voice box. And that's why when we detect early, we can do radiotherapy and we can preserve the larynx. Otherwise, we have to take out the voice box or laryngectomy. So how about nasopharyngeal carcinoma? Again, nasopharyngectomy. So it is not an easy surgery because it is at the skull base and we need reconstruction. And fortunately, these squamous cell carcinoma responds very well to your radiation therapy. If you combine with chemotherapy, the prognosis is increased. And for neck nodes, we can use we can do neck dissection for curative management. But in China or even in Sarawak, nasopharyngeal carcinomas are very common. So in this area, they can do they do nasopharyngectomy for recurrence or residual cases. If you still expect cure. So nasopharyngectomy. But other than that, radiation therapy and chemotherapy are the mainstay of treatment for nasopharyngeal carcinoma. So how about the epidemiology of these head and neck malignancies? It is common throughout the world, and it is 6th most common cancer worldwide in 2018, and in USA, 4% of all malignancies are the head and neck cancers. And it is common in old age, and males are more affected than female. So old age men, these are the risk factors for these head and neck malignancies. And majority of the tumors are squamous cell carcinoma. That's why we usually call head and neck squamous cell carcinoma. Other types are adenocarcinoma, for example, salivary gland tumor, adenocarcinoma is there. So how about epidemiology in Malaysia? So according to Malaysia National Cancer Registry 2012-2016, actually it was published in 2019. So nasopharyngeal carcinoma is the fifth most common cancer in Malaysia. So it is fifth most common cancer in Malaysia. And how about the staging at the time of diagnosis? So here you can see stage 1 and stage 2 are only 30% and more than 70% are late stage at the time of diagnosis. That's why in the CPG, Clinical Practice Guidelines in Management of Nasopharyngeal Carcinoma Malaysia, it mentioned that majority of nasopharyngeal carcinoma patients present with advanced stage at the time of diagnosis. It is due to lack of awareness of these symptoms and signs among patients and doctors as well. So here you can see the cardinal features of nasopharyngeal carcinoma. So among them, neck lumps or neck swellings is the most common one. Other than that, nasal symptoms, ear symptoms, and ophthalmoneurological symptoms are there. So we want to find out the possible causes of delay in diagnosis. So here I found one study done in Sarawak General Hospital in 2006, but it was published in 2011. So 42 consecutive cases diagnosed to have cancer between July to December 2006. So they want to find out time interval between onset of the symptoms to first medical consultation, to first specialist clinic consultation, and diagnosis and treatment. So they found out that most of the cases diagnosed at advanced stage, main problem is patient themselves delay. So they found out that patient's delay is due to the lack of awareness of these symptoms and because of traditional treatment, traditional medicine, and because of Sarawak is a big state and lack of accessibility to healthcare facilities. Another significant delay is because of our frontier health workers to identify sinister symptoms of malignancy. So they do not think this is a possible malignancy. That's why there is a delay in diagnosis. But timing for diagnosis and treatment after specialist referral, they found out it was comparable with other published studies. So the main problem is patients' delay and our health workers' a problem. So the authors recommend that first-line health workers, these are the doctors, medical assistant, nurses, play the key role to identify that sinister symptoms. They should have high index of suspicions and they have to do early referral to get early diagnosis and early treatment. And they also recommend for us as a teaching institution to give more emphasis on these common head and neck malignancies. So this common head and neck malignancy is included in our year 4 ENT curriculum as well. So how do we get early recognition or early detection? So we all know it is for survival. So we have two types of early recognition or early detection. One is screening and the other one is early diagnosis. So screening means identify the individuals before they have developed symptoms, or early diagnosis is by patients itself. They have to come to the doctors or healthcare workers. We have to identify correctly and do timely referral to the specialist. So early recognition by doing screening or by doing early diagnosis. So how about the screening? For head and neck malignancy, there is no routine screening so far, even though we have some screening program in some countries, but no routine or screening. But for nasopharyngeal carcinoma, we have serological test commonly do in China especially. But how about in Malaysia? So in Malaysia, they did not recommend NPC screening as a public health policy because there is no evidence on the cost effectiveness, no evidence for reduction in mortality. That's why they do not recommend. So we do not have routine head and neck screening in Malaysia as well. That's why early diagnosis is more important to get, early stage. So that's why when to refer these patients. So we have to be very careful if the patients are old age, men with chronic smoker. Because cancer commences in old age, men with history of chronic smoker. So usually I teach in the year 4 program. So if patients present with hoarseness of voice for more than 2 to 3 weeks, if patient is old age man, chronic smoker, until proof otherwise, it is C. larynx. So you have to refer to the patient. And another one is unilateral hearing loss with underlying otitis media with effusion. We have to exclude nasopharyngeal carcinoma, especially in old age. And features of unilateral sinusitis. So because sinonasal tumor, nasal tumor, in early cases, they present as features of sinusitis. Features of sinusitis like nasal discharge or blood-stained nasal discharge or yellowish nasal discharge or nasal obstruction. If it is unilateral, we have to be careful, especially in old age men. So if you see old age men with chronic smoker with these symptoms, you have to refer these patients. And how about other tumors for oral cavity or oropharynx tumor? So usually non-healing ulcer in the oral cavity, we have to be careful. And whitish patch or reddish patch, for example, that is leukoplakia, erythroplakia. These are the pre-malignant conditions. So then we have to do a biopsy to exclude malignancy. So if you have patients with these symptoms, so you have to refer the patient. So salivary gland tumor. So most of the salivary gland tumor are benign tumor, especially in parotid gland. But we have to know signs of malignancy. The signs of malignancy in salivary gland tumors are pain and cranial nerve palsy. For example, in parotid gland, facial nerve involvement is very early in adenoid cystic carcinoma. It is so perineural spread is early in malignant tumor. That's why these are the signs of malignancy. So if you have a patient with salivary gland tumor with cranial nerve palsy or pain, you have to refer. This is possible malignant lesion. So in thyroid as well, so usually solitary thyroid nodule is a risk for carcinoma. So if you have these cases, you have to refer to the specialist opinion. So we also need public education, because prevention is better than cure. So we have some measures to prevent these head and neck malignancies. So for example, avoidance of smoking and alcohol drinking, or practice healthy lifestyle, dietary care, or HPV vaccinations. Then we can prevent head and neck malignancies. And if they have these symptoms, then they have to seek medical advice promptly, also to get early diagnosis and early treatment. So for take-home messages of my discussion is head and neck malignancies are very huge consequences of patients, family, and for country. And early detection is very important to improve the survival rate. So we have to be aware of early signs and symptoms, and we have to do timely referral for the specialist opinion. Okay, thank you very much.
Thank you so much, Prof. Nillar, for a nice presentation on the early diagnosis. We will just check if I request the participants to post your questions in the comment box. I think a lot of them are just wishing us good afternoon, each other good afternoon. Actually, there is one question from Prof. Razif Ali. He has just posted that predisposing factors to nasopharyngeal carcinoma, can it be food, smoking, or industrial toxicants?
Thank you, Prof. Razaf, for your questions. Yes, for nasopharyngeal carcinoma, salted fish is a known etiology for nasopharyngeal carcinoma. Then it is in China, the both people, they prefer salted fish. That's why in nasopharyngeal carcinoma associated with eating salted fish, this is because of nitrosamines. Nitrosamines. And smoking, definitely, it is a known etiology. And industrial intoxicants, yes, industrial intoxicants, sometimes not nasopharyngeal carcinoma, but nasal tumors. They are a risk for the nasal tumors. Yes, Prof.
Thank you, Prof. Nilar. So I think we'll just wait for the participants to post their questions.
Yes.
Prof, just another question from me. What about the advancements in the diagnostic techniques? Do we have any recently achieved, like say, for example, endoscopic or any quantitative analysis that could actually open new perspectives for early diagnosis?
For early diagnosis, we have to do examination, screening and examination. But if you have indication, we can do guided biopsy. So guided
Guided
biopsy
by.
means we suspect that malignancy in that particular area,
Mm,
then we can do guided biopsy. But for these head and neck malignancy, yes, we can do nasoscopy
mm,
biopsy,
mm.
laryngoscopy biopsy, and
Absolutely.
so on. Yes.
Okay. So if you're suspicious of any lesions, I think you mean to say that it's better to confirm earlier, right?
Yes.
Yeah. Okay. We just wait for a few seconds, Prof, if we have any other questions.
Yes.
What about EBV etiology, Prof? Epstein-Barr virus, secondary to that, if you're experiencing. So, what are the risk groups that you should be really cautious about expecting a carcinoma?
Um, EPV virus is a well-known associated with your nasopharyngeal carcinoma, but we don't know we have that virus infection, right? So that's why we have to do screening for EB virus. So usually screening is done in endemic area like China. So
So,
EB
is
virus, yes, EB
serological
virus,
screening for the
yes,
EBV?
yes, serological study, that is EBV antibody or EBV antigen, or sometimes we can do nasopharyngeal swab,
Swab. Okay.
yeah, swab for EB virus infection as well. Not only
Okay.
serology, but we can do nasopharyngeal swab or we can do biopsy as well.
Okay. So, how far is the incidence of the sequelae? Like, if a patient is EBV positive, how much percentage does he carry the risk of developing cancer?
Yes, there is a high risk.
High risk.
High risk. If you have EB virus infection, it is a high risk of nasopharyngeal carcinoma. So that's why if we have an EB virus infection, then we have to do biopsy. Next step is biopsy of, because nasopharyngeal carcinoma is common in nasopharynx, a specific site, we call it fossa of rosemula, behind your eustachian tube opening. So fossa of rosemula, so we have to do biopsy, yes.
Okay. Okay. Thank you, Prof. Thank you for your answer, patiently answering all the questions. And I think not further questions, Prof. So with that, I think we come to an end of today's CME. And thank you for taking time to present in our CME event. And hope to have you again in another CME event. Thank you so
Thank you
much,
very
Prof.
much.
Yeah,
See
thank you.
you again.
Uh, thank you all of you for attending the CME event today. So with this, we come to the end of this CME event, and this is the last CME event for this academic calendar of our committee. And I think we will resume our CME activities from the month of October. So this is the last event for this academic year. So it was very nice to have a good attendance over the period of all the CME events that we conducted in this year 2021-22, and hope to have many more sessions in the coming year. And thank you so much, and all of you take care, and until we meet again in another CME event. Thank you so much.